अस्सलाम वालेकुम।
वालेकुम सलाम सर, क्या हाल है?
नौशद साहब, क्या हाल है आपका? खैरियत है?
अल्हम्दुलिल्लाह, बिल्कुल ठीक ठाक, बिल्कुल ठीक ठाक,
आपकी
फर्स्ट
क्या नहीं?
क्लास।
प्रोफेसर सुहेल साहब, सुहेल तारिक सुहेल साहब,
जी
सलाम
जी
वालेकुम।
जी, सलाम अलैकुम जी।
सर क्या हाल है सर? आप जवान लग रहे हैं सर।
फिर इस तरह ही ਹੁੰਦਾ ਤੁਸੀਂ ਜਾ ਕੇ ਕਸ਼ਮੀਰ ਜਾ ਕੇ ਬਹਿ ਗਏ ਸਾਨੂੰ ਛੱਡ ਕੇ ਤੇ ਜ਼ਾਹਿਰ ਹੈ ਕਿ ਫਿਰ ਫਰਕ ਤੇ
वो
ਪੈਣਾ
सर
ਹੀ।
इस वास्ते ਤੁਹਾਨੂੰ ਵੈਬਿਨਾਰ ਤੇ ਬੁਲਾਇਆ ਨਾ ਸਰ, ਤੁਹਾਨੂੰ ਵੈਬਿਨਾਰ ਤੇ ਬੁਲਾ
ਤੁਸੀਂ
ਕੇ
ਸਾਡੇ ਨਾਲ ਮਿਲਦੇ ਗਿਲਦੇ ਰਹੋਗੇ, ਜਵਾਨ ਰਹੋਗੇ।
राइट सर, आप ठीक हैं? आप ठीक है? नदीम को
अल्हम्दुलिल्लाह।
भेजा था, नदीम को ले। आप पहले एक दफा जरा शेयर करें ना प्रेजेंटेशन, फिर देख लेते हैं आवाज ठीक है आपकी।
ठीक है।
नदीम, सलाम वालेकुम।
सलाम अलैकुम नदीमा, भेज दे जरा।
जी सर, क्या हाल है?
ऐही भेज।
इसकी रिकॉर्डिंग मैं आपको फिर भेज दूंगा।
नहीं, मुझे तो कोई जरूरत नहीं रिकॉर्डिंग की।
सर आप देखेंगे ना, हम तो फिर शेयर कर लेंगे ग्रुप में।
हाँ हाँ हाँ।
ऑर्थोपेडिक के ग्रुप में शेयर कर लेंगे।
ठीक है। भेज दे, मैं जरा देख लूँ।
Assalamu alaikum, everyone.
जी प्रोफेसर
वालेकुम सलाम, वालेकुम
क्या हाल है?
Alhamdulillah जी.
प्रोफेसर
मौसम अक्टूबर
सुहेल
में
साहब, तारिक सुहेल साहब, प्रोफेसर सलमा कुंदी हैं, प्रिंसिपल वुमेन मेडिकल कॉलेज मुजफ्फराबाद, अपना
माशाल्लाह,
एबटाबाद की। और
माशाल्लाह जी।
ये
Assalamu
हमेशा
alaikum,
माशाल्लाह अरेंज करती हैं
thank you for
वेबिनार।
being here.
मैडम हमेशा वेबिनार पीएमए का अरेंज करती हैं, हम तो इनके बस इनको सपोर्ट करते हैं।
मुलाजिम साहब,
नहीं नहीं
ये
नहीं,
सारी आप ही की एफर्ट्स हैं जी.
आप whenever you need our support, I am always there.
थैंक यू सर, थैंक यू।
तो नहीं,
मैडम सलमा कुंदी,
मैडम,
तारिक साहब मेरे बचपन के दोस्त हैं, तारिक सुहेल साहब।
Okay, माशाल्लाह माशाल्लाह.
और ये मेरे मतलब कि मैं अगर किसी को कहूँ ना कि आर्थोपेडिक में किसी को इलाज कराएं, कोई मुझसे पूछे ना कि कोई इलाज आर्थोपेडिक का, तो मैं सिर्फ एक ही बंदा बताता हूँ।
Okay, good.
यानी मैं अपनी फैमिली को या किसी को कोई मुझे बताया ना कि जी स्पेशली ही इज एक्सपर्ट एंड स्पाइनल सर्जरी का, बहुत मशहूर है माशाल्लाह।
तो कौन से हॉस्पिटल में करते हैं?
मैं
ये
डॉक्टर
आजकल डॉक्टर हॉस्पिटल रिटायर्ड है, ये कई से मेरे साथ रिटायर हुए थे।
लेकिन अब
अब
ठीक है,
मैं
लेकिन
प्राइवेट
डॉक्टर्स हॉस्पिटल में है ना?
जी जी जी, आई एम विजिटिंग फैकल्टी इन a couple of countries abroad. तो उधर
Okay, that's great.
कुछ स्टेट्स में फैकल्टी में हूँ, जोहानिसबर्ग यूनिवर्सिटी में हूँ, हाँ, कोरिया में भी एज विजिटिंग फैकल्टी हूँ। भाई साहब,
Okay. कोरिया सुना है काफी एडवांस टेक्नोलॉजी में गया है, खासकर स्टेम
बहुत
सेल
ज्यादा,
में.
बहुत ज्यादा।
तो बहुत ज्यादा वो है। गिव मी फ्यू मिनट्स डॉक्टर तारिक, कैन यू
टेक योर
शेयर योर
टाइम।
प्रेजेंटेशन?
बिल्कुल, टेक
कैन यू
योर
शेयर
टाइम।
योर टाइम? नहीं, बिफोर दिस कैन यू शेयर योर प्रेजेंटेशन?
आपको
नदीम, कैन
भिजवा
यू शेयर
दिया।
योर प्रेजेंटेशन?
ये सर व्हाट्सएप कर दिया आपको?
नहीं नहीं, नॉट लुकिंग योर प्रेजेंटेशन।
व्हाट्सएप पे कर दी सर, आपको सेंड कर दी।
नदीम, प्रेजेंटेशन शेयर नहीं हो रही?
अच्छा सर, स्क्रीन शेयर कर दूं?
नहीं,
आपको मैंने व्हाट्सएप पे भेज दी है वैसे।
नहीं मैं व्हाट्सएप पे शेयर नहीं, आप इनको देना एक्सेस दें अपने, इसके ऊपर जूम पे शेयर करें।
अच्छा
वदीद अपना सर को बनाए ना आप, वदीद सर को बना दें अपना,
पोस्ट बना दें सर।
अलाउ कर दें, शेयर प्रेजेंटेशन शेयर
सर
करें।
आप अपनी स्क्रीन शेयर करें सर, आपके पास राइट्स हैं सर।
ठीक है,
नहीं मैं आपको कर देता हूँ ना, आपको कर देना, मैं आपको व्हाट्सएप
नहीं
शेयर
सर,
करने लगा
डॉक्टर
हूँ।
तारिक की बात कर रहा हूँ कि उनके पास राइट्स हैं, वो शेयर कर सकते।
शेयर कर दें,
कर रही हूँ।
कर दें।
वदीद मैं आपको भेजने लगा हूँ उनकी प्रेजेंटेशन,
ओके जी।
अगर ना हो सके।
जी सर देखें बुक के।
ये आ गई है प्रेजेंटेशन, आ गई है। ओके ओके ओके, गुड गुड गुड। अच्छा, इसमें ना नीचे पावर पॉइंट पे आप जाए ना, पावर पॉइंट उसके ऊपर आप स्क्रीन, ये प्रेजेंटेशन है ना, स्लाइड मोड पे जाएं।
सर भी कर देते हैं।
ठीक।
ओके 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 ओके, अब इसको बंद कर दें, अब इसको बंद कर दें।
टेस्ट करना
आप नहीं, okay. A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Before starting today's presentation, I will request Dr. Professor Rashid Saab to start today's session with Holy Quran.
Right, sir. Jazakallah.
No,
A'udhu billahi minash
recording has been
shaitan.
started.
Right. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم كلا بل تحبون العاجلة وتذرون الآخرة وجوه يومئذ نادرة إلى ربها ناظرة ووجوه يومئذ باسرة تظن أن يفعل بها फाकिरा। ये सूरतुल क़यामह की आयत है, थोड़ी सी इसका तर्जुमा है। खबरदार, असल बात यह है कि तुम फौरी तौर पर हासिल होने वाली चीज यानी दुनिया से मोहब्बत करते हो और आखिरत को नजरअंदाज किए हुए होते हो। उस दिन बहुत से चेहरे शादाब होंगे, अपने परवरदिगार की तरफ देख रहे होंगे, और बहुत से चेहरे उस दिन बिगड़े हुए होंगे, समझ रहे होंगे कि उनके साथ वो मामला होगा जो कमर तोड़ देने वाला है। सदक़ल्लाहु अज़ीम।
Thank you so much. Thank you so much. Thank you so much. Jazakallah. Jazakallah. Alhamdulillah. Today we are starting 84th webinar. And this webinar is in collaboration with South Asian Association of Pathologists, Azad Jammu Kashmir Medical College, Muzaffarabad, Women Medical College, Abbottabad, Pakistan Physiological Society, and Pakistan Association of Pathologists. Professor Dr. Salma Kundi is the host of today's session, and she is the principal of Abbottabad, Women Medical College, Abbottabad. And I will be the moderator, and there is the principle that we will start today's session. At the end of the session, there may be a few questions, and Dr. Tariq Sohail. Dr. Tariq Sohail, introduction, no need of the introduction. Dr. Tariq Sohail retired from the King Edward Medical University as a professor and head of the Department of the Surgery, Orthopedic Surgery. Dr. Tariq Sohail is the writer of so many books and is known by his innovations. Especially, he is a specialist of spinal surgery. Dr. Professor Tariq Sohail, over to you.
Thank you. Thank you, Bukharisa, for very kind introduction, and it's very nice to talk to so many renowned personnel in your part of the world, and I think it remains to be. I think I would love to be there, at times, because I heard a lot of good about that institute and that part of geography. So what I'm going to speak is tuberculosis spine. I don't know, but it's just a general concept, and it's just a general management. I'm not going to the more details of all these things because it may not be very exciting to a lot of people because it needs some surgical sort of, I would say, with the procedures and their how you do it. But I think I will just talk about the general concept and how we manage it. It's tuberculosis is very common in India and Pakistan, and I think it's most commonly it's a spine which is involved. in musculoskeletal and most common in the first 3 decades of life. And it's one of the oldest recognized tuberculous, involvement of the spine. It has been mentioned in the Egyptian mummies, and the mummies have been dissected and shown to be kyphotic deformation with the impingement of the spinal cord. And they are still in display in various museums around the world. And that's your earliest. And at that time, they recognized that once a tuberculosis occurs, it is a fatal disorder because it will impinge the spinal cord and it will lead to paralysis. Once a paralysis occurs, then it ceases to exist. That it's not good for health, and the patient they tend to die over the period of time because of neurological complication of tuberculosis and the complication of paraplegia. And the role it plays in the early demise of the patient. Historically, Percival Pott described in 1779, and I have the privilege to work for some time in the same place where the Percival Pott was there. And he described the destruction of the disc space and the adjacent vertebrae lead to collapse of spinal elements and the progressive spinal deformity. So I think it is just a progression of a chronic inflammatory disorder which leads to a loss of disc space, adjacent vertebral damage, and ultimately loss of interior column of the spine and progressive kyphotic and spinal deformity, which results not only soft tissue damage and the damage to the nerves, root, and spinal cord, which may be slow to begin with, but ultimately the both pus, granulation tissue, sequestry, and mechanical pressure of the collapse of the kyphotic vertebrae, they produce damage to the cord and produces neurological sequelae of infection and the deformity which comes after that. Robert Koch discovered the mycobacterium in 1882, and that is still one of the main cause of mycobacterium or the tuberculosis infection. But having said that, because of advent of HIV and other immune compromising disorders and the therapeutic sequelae in cancer or other patients, the new species they are emerging, which probably need some different therapeutic strategy. And also the new problem which coming up is that the bacteria which used to cause tuberculosis in the olden days, they become resistant, and the prevalent first line of drug is no more effective in quite a number of patients. And I think it's becoming an epidemic, not only India and Pakistan, but also in African countries. And the new drugs, they are being introduced. In Pakistan, I think not all the drugs, they have been introduced as a second line in the resistant situation. But nevertheless, they are there, and they can be treated adequately and quite satisfactorily with those medications. If you look at the epidemiology, it's a leading cause of death from the worldwide from the single infection agent disease. So I think important lies that it is still one of the leading cause, and the cause is not only pulmonary infection, but also the secondary infection from the pulmonary or the gastrointestinal or genitourinary to the spinal infection. And the spinal infection, it is the deformity and the neurological damage which it causes that produce paraplegia or neurological deficit, and the patient develops other complication because of that. And I think it is related to the economic condition of the geographical area. The poor patient, both in Asia, Africa, they have a higher number of tuberculosis patient. But the so to say first world or the affluent societies in Europe and America, they are now having more number of patients of tuberculosis, though they do not recognize it, they do not anticipate it. But I think now they are realizing that tuberculosis is there in those countries as well because of human migration, but also the disease pattern is changing because HIV and other disorders which disable your immune mechanism and predispose the patient to tuberculosis. So I think the number is quite a lot, 8 million every year, and quite a number of patients they involve musculoskeletal disorders. And of the musculoskeletal, 50% they are in the spine as well. Still one of the predominant predisposing factors is malnutrition, poor sanitation, overcrowding, and close contact with the tuberculosis patient, and the multiple pregnancy and immune deficient states. So I think these things here are there in our setup in Asia, in Africa, and other developing countries, which are still struggling with both economic and population explosion. And in these patients, we still have not been able to control the disease in a study, despite BCG vaccination, despite the government measures to install adequate medical treatment by direct observational therapy or otherwise. The people, they are not very sort of compliant. They take a very casual attitude towards medication, and ultimately succumb to the disease and end up in complications. As I said, Mycobacterium tuberculosis, it is there. It is a hematogenous spread from the primary site in the pulmonary or the gastrointestinal tract, and ultimately it involves the bone and joint. This is the pathology. You know much better than I do, and I don't have to tell them, but I think it's a phagocytic inclusion, the bacteria, tuberculosis bacilli, by the mononuclear cell. Ultimately, the epithelial cell formation occurs, the giant cell formation by the fusion of various epithelial cells. Then there's a chronic lymphocytic reaction around this epithelioma, and what gets is tubercle formation, which is very typical of tuberculosis infection under the microscope. And I think you guys are much more experienced and versatile in this pathology. This is again tuberculosis bacilli being engulfed by the mononuclear cells and epithelial formation and tuberculosis formation. And this is a close-up picture of that. And I think it is a secondary infection in the spine. Primary is somewhere else, usually either in the lungs or in the gastrointestinal tract, or in the genitourinary tract. And in our setup, GI is not uncommon, because a lot of patients, they have infection which is subclinical, and they develop often on pet kharab ho gaya, ye ho gaya, wo ho gaya. But I think ultimately they have poor nutrition, poor environment, and this disease which has been lurking there for some time, and with a acute depression of various contributing, like a poor nutrition, neurohydrogen, any disease which occurs and causes immune deficiency. Diabetes is one of them, and it is very common in our setup. So I think a diabetic patient, on their own, they have a severe impact on the immune system, and ultimately lead to the resurgence of various disorders which are sort of lurking around, but with the immune deficiency, they become apparent, and they produce various kind of infection, and tuberculosis spine is one of them. And usually it's a hematogenous, and they are primary focus through somewhere else in the disc space. Ultimately, they lift up the periosteum and the spinal, vertebral envelope of the soft tissue, and disc is destroyed and phagocytized by the various cells and the enzymes which are related, which are released by these bacilli, and ultimately disc is eaten away. The periosteum lifts up and produces a sort of damage to the bone, which is again a result of local vascular action of chronic inflammation or the acute inflammation, and that produces necrosis of the bone, and ultimately the vertebrae, two adjacent vertebrae collapse, and they produce local loss of kyphosis, or the loss of lordosis and kyphosis. Then it produces not only deformation, but in acute stage, the pus, granulation tissue, and all this material, they track backwards into the spinal canal and produces further inflammatory reaction, impingement of neural tissue by not only pus and granulation, but also by the mechanical sort of disadvantage which puts this neural tissue under, and produce various neural impingement in terms of nerve root entrapment, and also the direct compression of sac, and may produce neurological symptoms. So I think acute stage, all this happens, and this is if you look at the continuous continuation of infection, it produces the two vertebrae which are involved along with the intervertebral disc, and ultimately they produce loss of bone and loss of curvature, and that produces kyphosis because of destruction of the disc, destruction of the bone around the disc space, the further jeopardization or the loss of vascularity to the adjacent vertebra, that produces custom. And so all this milieu of acute inflammation, which produces damage to the bone and the other tissue, produces kyphotic deformation, and that loss of anterior column occurs, and that produces local sort of kyphotic deformation, which may progress to quite significant and produce neurological damage in way of either pain and paresthesia, or the paralysis in these patients, and that results into the neurological impairment. And if it's bad enough, that produces visible kyphosis, and that produces functional disability, and the patient becomes unable to be up and about, and they develop sort of a problem with this. So if you look at the pathogenesis, there is osteoporosis due to hyperemia. There's ischemic necrosis because of peri and arthritis. Disease itself produces acute and chronic inflammation and infection, and that produces all this results into destruction of the vertebra, and that destruction of the adjacent vertebra produces collapse, and that produces progressive deformity. And if it's a two just adjacent vertebrae producing acute kyphotic deformation, it will produce kyphosis or the gibbous formation. And if you have a more than two vertebrae, which is not unusual, it can produce a much more acute kyphosis and acute angulation, and that produces much more severe neurological damage with the disease process. These are the various areas which are involved. Dorsal lumbar is the area which is much more at risk because of biomechanical changes in the thoracolumbar junction. But having said that, the other region, they are not immune, and cervical and the lumbosacral junction, they are equally affected, though they are recognized sometime a little late because of complex anatomy and the complex symptomatology in the occipitocervical and the lumbosacral junction. Thank you. Yeah, I think. So these are the various types of paradiscal, central, which is usually paradiscal is when you have this is a classical sort of initiation, and paradiscal area is an occlusion there, and that separates involves the disc and the adjacent vertebrae. Then you have central, in which this there is an occlusion in the center of the vertebra, and that produces a sort of just isolated collapse of the vertebral body. And then there is an anterior subperiosteal spread, and sometime in the only 10 to 15% of the patient, they have this spread which is starting in the either in the canal or in the posterior complex of the spine, like spinous processes or the laminae, and these are the areas which are unusual, and they present in an unusual manner. They present with just paresthesia and some sensory impairment in the legs, and ultimately they develop sort of neurological compromise. The pattern is entirely different. It's more like a tumor-like, and if you look at the X-ray, their bone density is much smaller, and there's no visible deformity. There's no anterior column problem, and the patient presents, and it is reported most of the time as a normal X-ray. because the ribs, especially in the thoracic spine, they overlie these posterior spinal complexes, and they do not let the pathology become more evident in the plain X-ray. And it's only the MRI which gives you sort of picture that there is something going on. In the active stage, there are more of a constitution symptom, malaise, loss of weight and appetite, and night sweats, and evening rise of temperature. And along with that, there is a stiffness, there may be a deformity, there may be restriction of the range of motion, they may be having enlarged lymph nodes and abscess formation, which may or may not be draining, but sometimes it presents in the subcutaneous area. And along with that, there is a neurological deficit depending on the site and the extent of the disease in these patients. But in a healed stage, or in the patient who presents a little late when the disease is already confined to a certain area, the stiffness, deformity, and restricted range of motion, there's much more as compared to the malaise and other symptoms, which are sort of expression of acute sort of stage. And in a chronic stage, then neurological deficit on ambulation is much more evident. If you look at the neurological deficit, it is something like 10 to 30% develop neurological problems in the way of pain and paresthesia and paraplegia. And the disease below the vertebrae rarely cause paralysis, but because of the lower motor neuron type of lesion. But in the thoracic spine and the cervical spine and the occipital-cervical area, the disease is much more sort of, I would say, can result into paraplegia and may or may not recover. But I think in tuberculosis, good thing is that usually if you adequately decompress it, adequately treat it, then the tuberculosis recovers even in the cervical and in the thoracic spine, and provided that there is no ischemic necrosis or the ischemic changes in the spinal tissue. There are you can classify as an active and chronic stage or the healed stage. In the active stage, as I said, usually the malaise, weight of loss, and weight and loss of appetite and other symptoms, they are much more prevalent. And the underlying pathology is edema, granulation tissue, abscess, and the caseous tissue. And along with that, there may be ischemic changes in the cord because of chronic inflammation or acute inflammation. It will result into ischemia of the cord as well, along with the ischemia of the bone, which produces. But if you treat it in the early phase before there is a deformity, you can anticipate good results. But apart from that, there may be a sort of abscess formation, and that abscess produces sort of compression to the cord, and also involves some impairment of the vascular element, and that adds to the insult and adds to the necrosis of the not only the bone but also the neural tissue. And if you have a deformation, if you have a necrosis of the bone, and that necrotic bone will sequestrate backwards and produces mechanical pressure on the neural cord. And it carries a poor prognosis, because if it's not treated adequately, it will lead to chronic damage. You can stage it depending on the pathology from negligible to the severe. Depends how extensive the pathology is, whether it's just minor infection there with a minimal symptom, or to the severe infection where there's pain, there's a pain muscle spasm, there is a paralysis or neurological symptom, and there may not be any sensory deficit, and there may be flaccid or spastic type of paraplegia, and depending on the problem of the extent, the sphincter may be enrolled, and the patient becomes sort of risk of running more complication because of tuberculosis and the sequelae of tuberculosis infection in these patients. Pathology, as I said, is edema of the cord, neurological deficit because of vascular impairment, and also the toxin which produce. And this is usually tuberculosis infection and abscess. This produces not only acute inflammatory changes, but also mechanical pressure there. And that is because of granulation, osseous material, sequestration of the bone, and the pus as such. as I said, that the bony problem, which basically results into the mechanical impairment of the spine. If you look at the normal mechanics, the 80% of the weight bearing passes through the anterior column, which is mainly vertebral body and the intervening disc. And if you have a loss of anterior column, either because of any disease in which results into like infection, tuberculosis infection, which results into the loss of disc, lot of loss of bone in the vertebral body, it will produce mechanical imbalance, and the normal balance between the anterior and posterior column is lost, and the patient develops kyphosis, and that produces a kyphotic deformation either in a one level or maybe at the multiple level, and that produces changes. Then again, as I said, that one of the pathological changes is the meningeal irritation that produces local meningitis because of inflammation, and usually it results into the local scar because of repair of the inflamed tissue, and maybe that scar results into local stenosis and local entrapment of the neurological tissue. And the tissue around is also thickened. Usually dura is not involved in the initial stage, but in the chronic stage, the dura is also involved and thickened, and that produces additional mechanical impairment. So if you look at the changes in the spinal cord, there may be enteritis, periarteritis, and thrombosis occurs, and that results into, in certain situations, acute onset of the paraplegia. That is because of vascular impairment, not because of neurological impairment, because of mechanical or other reasons, which are slow in onset, and they progress over the period of time. When you have a patient with acute loss of function, that is because of vascular impairment. And these carries a bad prognosis because it is irreparable. If you have a chronic progression, which is slow, that is better in terms of outcome. That's various pathology of the tuberculosis, paraplegia, changes in the spine, loss of neuron and white matter. There is a myelomalacia in these, if you look at the MRI. And extradural granuloma and tuberculoma, along with the scastum, they present local pain. Clinical feature, as I said, I have said earlier, there's a paraplegia does sometimes present, tuberculosis paraplegia does present sometimes with neurological deficit in the first instance, but usually they come with a chronic, acute and chronic inflammatory changes, which has a lot of systemic element. But sometimes it presents, on its own. With a paraplegic, especially if you have a situation like diabetes, in which the neuropathy may sort of superimpose upon the underlying pathological process, and the patient may not have that sort of sensory input, and the patient develops a sort of neurological problem. But spontaneous muscle twitching, clumsiness walking, extensive plantar response, exaggerated reflexes, and motor deficit, they are all the indicators. So I think that, belie that patient, one should take a proper history. One should spend some time, take a examination of the patient, both upper and lower limb, and also look at the spine and feel the spine. And if you look at the spine, there may not be apparent deformity, but I think if you deep sort of percuss it, and a patient will develop pain, demonstrate the pain, and that has to be taken into account and investigated adequately. Prognosis, the initial acute stage, they have a better prognosis. Shorter duration is also it's a good prognostic sign. And the early onset tuberculosis, which you catch on early, it carries better prognosis. Onset slow, if you have a slowly progressive disease, it carries a better prognosis compared to acute and rapid onset that carries a poor prognosis. General condition, if you have a good general condition which is compatible with the disease, it carries that shows that the patient have a good nutrition, good immune status. But despite that, infection can still occur, and that can be helpful for the patient, the treatment. Vertebral disease with a minimal loss of sort of posture or the bone, and it is active. You can you can treat them with the medical drugs and etc. without going to surgery. But if you have a kyphotic deformity, the more the kyphotic deformity is there, more the angulation is there, the more the severe prognosis, the severe kyphotic deformity and the neurological deficit occur, and the more the prognosis is sort of poor. So I think a degree of deformity at the time of presentation is very important, because if you have something like 30 or 40 or beyond, then it poor prognostic sign. And say, if you have a younger patient who has more than 2 or more vertebrae involved, then these are bad prognostic sign. And children, you have to be wary that the child is growing, the spine is growing, and you have to keep that in mind in treatment, both medical and surgical. And you have to take that account. Various other radiological features will come to later on. The MRI in the initial stages may be normal, nothing to talk about in that, but the disease process itself will show the MR changes. But MRI in an older, poor, in older patient with a chronic sort of setup, where there may be myelomalacia changes, and that carries a poor prognosis. So is the increased deformity, so is the healed tuberculosis because of the mechanical and other changes which I said earlier. General condition, if it's a poor, then it's a poor prognostic sign. So is the age and the rapidity of the paralysis that shows that there's maybe some underlying vascular element. These are just hematological tests which you do as a marker for the inflammation. I think ESR, C-reactive protein, and other tests, they are important. The Manto is out of window, not entirely, but I think usually it is positive for most of patients because they have been vaccinated. So if it's a negative with a lot of elements, both radiological and MRI, that patient is having tuberculosis. That means there is a sort of immune response is not strong enough to mount against this BCG test, and the patient develops negative test, but that does not rule out that it's not. It may be a miliary tuberculosis where the whole immune system has been overwhelmed. Biopsy, I think it is important not only because of to confirm the diagnosis, but I think even if you make it clinical diagnosis tuberculosis, you should still, I think, go for biopsy. You can go for a needle biopsy. You can do it under image intensifier or under CT scan, and you can get some tissue which you can subject it to histopathology. But also, if you have a pus, then you can have a PCR. Then you can have a gene positive, gene expert test, which will show that patient is gene expert is now available almost everywhere. Not only tuberculosis, but quite a number of patients, if which you have unusual tuberculosis, unusual pattern of presentation like posterior element or anterior single vertebral collapse, biopsy becomes more important because it may have a tuberculous sort of underlying disease, but may not have any other lesion. There may be some other pathology like myeloma, lymphoma. They are the lesions which produce a single vertebral collapse. And apart from that, they may be just a pure osteoporosis. But having said that, biopsy, to my mind, is important. And in our setup, in a patient who, I think, not who, but I think in our setup, the fungal infection is not uncommon. They present similar to the tuberculosis in their clinical and in their radiological manifestation, but the expression is a little different, and the response to the treatment is different. And despite your medical treatment, they do not respond adequately, and the patient have a progression of sort of disease process, And one assumes that maybe it's a tuberculosis which is resistance to ordinary drugs. So I think in those patients, one has to go take a good amount of material and subject to biopsy, including fungal infection, and that is important. And I think we do come across here and there patient who have a fungal infection. We have been treating them with a presumptive diagnosis that patient is tuberculosis, but it's not tuberculosis, it's fungal infection. That's why it's not responding, and the adequate treatment after fungal diagnosis becomes more important. Zeal Nielsen, I think LG Media, they're all there. I think the newer test like a Gene Expert and Backtech, they are important, and they a good sort of diagnostic tool. You can make a diagnosis within a few hours, and you can be very sure that it's a tuberculosis infection, and you can do the PCR, which will give you the nuclear material of mycobacterium. And the immune globulin is important. You should see that the level of immunity, and you should also look at the level of albumin, and you also the flow cytometry, and you should see the CD4 and CD8 counts and their relationship. And I think it's important to rule out in a patient who does not respond to the treatment, there may be some adequate, immune deficiency. So I think in the initial phases, you can rule out, depending on the severity and extent of the disease, the patient karna karane ke nahi PCR ke alawa bhi, like plain X-ray may be looking normal in the first, I think, but just a gentle small revision will give you diagnosis or the clue to the diagnosis, and you can go for biopsy and also the MR examination. I think radiological examination should be preceded by the biopsy, so that the intervention of biopsy procedure does not affect your radiological sort of appearance. This is the initial stages. There may be blurred paradiscal margin. There's a destruction of the bodies of the vertebrae. There may be loss of vertebral trabeculae and the loss of cortical continuity. And there may be soft tissue pre and paravertebral shadow, and there may be a subluxation and dislocation and decrease in sort of lordosis in the lumbar spine and kyphosis in the thoracolumbar spine. So I think it's just progression and extent of the disease which will dictate the radiological appearance. It may be appear normal in the first, the one part of the spectrum of radiological investigation, but if you go to the extreme of the established disease, it may present with all the parameters, radiological parameters, which will show that it's a tuberculosis with the various other material. And MRI will give you much more information in these patients. This is what happens in most of the patients. They come to us in this stage. They have loss of disk space. There is some element of repair, but there is a pseudarthrosis there. And if you look at there's a kyphotic deformation, and that has produced. I presume that if you look at the MRI, there will be impingement of the spinal canal and the impingement of the dural sac, and these patients present with a variable type of neurological deficit or the neurological symptoms. The cervical spine and the upper cervical spine is important because in a lot of patients, they present with some degree of sore throat, some degree of swelling disorder. कि जी वो जब खाते हैं तो निकलता नहीं सही. And if you look at the X-rays, any upper respiratory infection, especially the sore throat and the tonsil, they can precipitate the damage to the vertebral bodies, and they can produce local deformities. So in these patients, one should be very careful to evaluate, and these acute infection in the upper respiratory or in the upper part of the cervical oral cavity, they can produce involvement of the cervical spine, and they can present various kind of physical changes, and also neurological changes, and along with that, radiological and other changes. And this is difficult. You have to diagnose it early, because the prognosis can be difficult, and operation or the surgical correction can be difficult at times. So in these patients, it should be investigated. These are all sort of loss of parameters, the curvature of the spine. Sometime there may be skipped lesion. And tuberculosis does not occur in one sort of segment alone. It can be depending on the immune status of the patient, depending on the extent of the metastatic inoculation of the musculoskeletal tissue, the spinal column. One can expect, depending on the clinical picture and the history, etc., to be more than one area. You can, I won't be surprised, the cervical and the thoracic, or the thoracic and the thoracolumbar, or the thoracolumbar. Any combination can occur, and they can present with a pain at two lesions, and they can present with one lesion producing neurological compromise, another lesion just sitting there and waiting to be going forward and producing damage. So I think one must be cognizant of the fact that it may be a polyostotic and polycystic, and one should be kept in mind, and one should investigate it. It just needs one X-ray and an MRI, and gives you a good amount of information, and you can plan the treatment accordingly. These are other radiological sort of, you can see this whole anterior longitudinal ligament of the spine is lifted up, and there's a multiloculated abscess in the anterior part of the vertebrae. There's a destruction of the one vertebrae, which is more pronounced, but the elevation of the anterior longitudinal ligament and the soft tissue anterior to the spine will produce damage to the vertebrae below as well, not only because of presence of pus and inflammatory tissue, but also the cardiac and the aortic pulsation will produce sort of eddy currents, and that will result in absorption of the vertebral body anteriorly, and that will add to the sort of deforming element, along with the osteoporosis and etc., and the infective element, which producing primary pathology. So I think MRI is very important, and they'll give you extent of the treatment, and give you the sort of guide you the management sort of clue. These are other radiological features. You can see this various features which are there, and various X-rays, which you can see. Just one vertebral loss, maybe just tuberculosis, which may be a central in it's a atypical tuberculosis because of atypical presentation in just one vertebral loss. But it may be because of osteoporosis, which may or may not be because of trauma, or maybe trauma is so trivial that patient doesn't remember, but it may be because of some underlying metastatic problem or the oncological problem, and they produce one isolated collapse. In these situations, one must go for all the radiological investigation, all the hematological investigation. Then you should take a biopsy and make sure that there is no tuberculosis, or there is no sort of disease process, or the oncological process which is going on, and whatever the material is there, it's non-infective, it's just a normal osteoporotic material. Occasionally, as I said earlier, the atypical lesion, we can call it in a multiple way, either atypical because of a bacterial inoculation, whereas normal bacteria, Mycobacterium tuberculosis is not there, some other bacterium is there, or usually it is taken by presentation in a different manner. Anterior column usually is the most common site, but in 15% or so, 10 to 15, it may be the posterior element, which is the primary source of infection, maybe a laminae, spinous processes, extradural inoculation and granulation formation. They all produce within, sort of normal X-rays, and only the MRI will show you the pathological changes and the extent of the pathological changes, which are there and produce various kind of. These are the other sort of problems. A patient may have a lateral shift and scoliosis, maybe kyphosis because of and this is healing is that produces a healed vertebra will produce some problem on its own, because in the initial phases, once you have an acute inflammation, acute gibbous formation, and acute progression of expulsion of the material into the spinal canal. But once that heals, it is still producing neurological symptom because of repair process results into fibrosis, resulting in heterotopic ossification in that spinal canal, and that produces a neurological problem. So I think in adults, one should anticipate the healed tuberculosis being presenting with various kind of pain and paresthesias, and one has to investigate it. But on the other hand, there may be some healed tuberculosis, there may be some localized abscess, like a Brody's abscess, which may not be apparent on X-rays and etc. Patient does develop pain, patient does develop neurological symptom, acute, which may be because of vascular or because of reactivation of tuberculous abscess within the bone, bony mass, healed mass. And once you go and correct it, once you go and investigate it, you will see the abscess there, and that can cause sort of a problem of neurology in a healed phase, which apparently looks reasonably well on plain X-ray. But I think these things has to be taken care. These are CT, these are MRI changes, various changes. Ultrasound is important for abdominal and pelvic sort of assessment of cold abscess or the psoas abscess or the sepsis into the pelvic area, which may penetrate underlying the inguinal ligament, and they can present with a pain and spasm on the hip, and there may be sometime abscess in the into the thigh, and they are usually undetected by the plain X-ray and patient. So I think ultrasound is also important. It will give you the location and extent of. Radionuclide bone scan is important because it will show you the increased tissue sort of destruction and also repair process. And the PET scan nowadays, I think, is equally important, and you should go for PET scan if it's available, and that will give you much more sort of much more help in diagnosis and extent of disease. And if you are going to see the progress as it's going in a good way or a bad way, I think PET scan is better than the MRI, because MRI changes will persist for quite a long time. So you cannot discern that the patient is getting better or not from the MRI. Clinical symptoms and etc. They will give you clue whether the patient is getting better, because the hematological parameters, they are getting better. But if you want to do if you want to assess the progression, I think the PET scan is better as compared to the MRI. MRI changes will will not give you the extent of disease elimination. Local changes will persist and they will give you a false picture. I think one important thing is that in children, the neurological impairment or neurological malalignment is important. It is just an expression of progression of disease from the minor gibbous formation or kyphotic deformation in which just posterior element, they are opened up along with the loss of vertebral alignment to the retropulsion and asymmetric sort of malalignment. It all depends the extent of the disease along with the extent of the bone destruction that produces impaired sort of X-ray picture, and that will tell you if you look at these signs, they will tell you the spine is going to be at risk and it will produce neurological tissue, neurological damage, and the patient will develop sort of a neurological deficit over the period of time if it's not intercepted in between. It can go from the figure A, which is a grade 1, 2, 3, 4, and it says you can put up a score, and that will give you various. So I think these are basic principles of management: early diagnosis, medical treatment. If there's a neurological involvement or a progression of kyphotic deformity, or if you want to prevent any deformity, I think surgical management is much more sort of effective. The medical management is usually the medication, and along with a good hygiene and etc. I think pre-anti-tubercular era was a good diet and etc. It will, and also the postural sort of correction, some kind of support there. But I think with a new medication, you can anticipate early response to the treatment, provided there's no gross deformity, there's no neurological problem, and the patient is up and about. You can treat an anti-tuberculosis treatment with a splintage in terms of brace and etc. But if there is any neurological problem which is progressive, which is disabling, which is causing loss of function and ambulatory effort, then I think surgery is there, and these patients should be corrected surgically. You can do the debrima. Basic principle is the debrima. Exposure of the bone, which is healthy and vascular, and it is bleeding freely, and then at the same time stabilize the spine from the back, and you should reconstruct the bone which has been lost by various bone graft material, which varies from the iliac crest to the other sort of type of bone, and you can augment it with some kind of cages which will restore the anterior column, restore the mechanics, and help in early healing process. These are the other sort of supportive rest, brace, and etc. Good nutrition. I think I should stop it here. These are the usual drugs which are available, which are being used. And I think they should be used. It's a medical treatment, which is the initial management. But as I said, if you have a neurological problem or a neurological problem of pain and paresthesia, which is progressive and causing functional disability, one should go and do the surgical correction. And the surgical principle is restore the alignment, restore the mechanics, remove the dead and dying bone, remove of the pus and granulation, and restore the bone stock. These are drugs which are available for these treatment. All spine tuberculosis do not require surgery. You have to start with the medical treatment, and you should anticipate response to the conservative and medical treatment. But if there's an indication for any deterioration, especially the neurological function, or the persistent pain, or persistent neurological symptom, or progression of those, then you should go for surgical intervention. Or if the patient presents with the pain and kyphotic deformation in an advanced stage, then you can give medical treatment for a short period of time for 4 to 6 weeks. And we're presuming that any active tuberculosis in those situations has been sort of taken care to a certain extent, then you should go for surgical correction. And surgical correction in those patients can be taken, as an individual patient who presents with a type of deformity, the extent of the disease, age of the patient, any underlying comorbid conditions, and also the other general condition of the patient, etc., especially the any pulmonary problem. Because in the 20% of the patient who had a spinal tuberculosis, 20% they have a TB of the active tuberculosis of the pulmonary tree. And if you do the thoracotomy in these patients, they will have a much more pulmonary complications, and which may be fatal at times. So I think nowadays we don't open the chest cavity. We don't do thoracotomy. We just do the costotransectomy, or extrapleural approach is very good approach, and you can do everything from the back and do the extrapleural approach, and you can do the correction of deformity and treat them in correction of removing all the dead and dying tissue, do the debris correction, and hopefully it will much better for the patient. Even in a patient who is very poorly, costotransectomy is a very good operation. It has been revisited. It has been relearned over the period of time, and I think a lot of people, they are now doing it because it does not need opening of the chest cavity, and it goes to the area where the disease, and you can correct. You do the debris, and you can put a bone graft, and you can correct the spine deformity at the same time. So I think with that, I thank you very much. There is quite a few more slides, but I've been told that the time is up for last few minutes. So I think I'll stop it. I'll be very happy to go at some of the time and do the surgical management or the kyphotic problem management in these patients. So I think that will complete the whole. So take-home message in all these patients is conservative management in most of the patients, provided the disease not very progressed to a level in which it produces a neurological problem. And it usually they respond to the treatment along with a good diet and a good environment. And you should give them braces, and that will correct the curvature as far as possible. You should give them medical treatment, and that will give you a good response. But on the other hand, you should keep that patient under review, and if they go for progressive neurological problem, which result into ambulatory difficulty and ambulatory disability, and I think with those patients, they should be reevaluated from surgical standpoint, and one should go for surgical management if there are indications. And if you're going for surgical intervention, posterior approach is the best approach. You can approach the whole spine. From the posterior approach, you can correct the posterior elements, you can correct the deformity, you can do the debris from the posterolateral approach from the same posterior incision, and you can expect better outcome after correction of deformity, after debris and after bone grafting. Along with that, medical treatment has to be instituted. And again, once you take the pus and granulation tissue, you should again subject it to the histopathology, so that you're not missing anything which has not responded to your earlier management. Thank you very much.
Thank you very much, Professor Tariq Sohail, and I would love if anybody allow the patients, people who want to ask the question. But before this, I want to ask my question. What do you think when you are going to manage the patients? You need the collaboration with the pulmonary tuberculosis specialist, or it is enough that it is dealt at the level of orthopedic?
You see, if you, in your assessment, when the patient comes with a suspected tuberculosis patient, you should look into the pulmonary aspect. You should take a history and tell you that the patient is having cough or hemoptysis or not. But if you have any doubt, take a chest X-ray, do the CT scan, and if there is any active disease, or there may be some dormant disease, one should assume that there is a tuberculous element which has been spitting out tuberculous bacilli into the circulation and causing metastatic infection. In those patients, I think you should get an opinion from the pulmonologist, see if their pulmonary function is okay, because these patients, they will need general anesthesia, most of the patient. And again, from the surgical standpoint, you should not do thoracotomy, because thoracotomy, if it's a tuberculosis which is there, which is an active tuberculosis, even it's a dormant tuberculosis, doing the thoracotomy will induce its own surgical stress, and they will it may help in reactivation of disease in the pulmonary if it's a thoracotomy is done, because during thoracotomy the lung is deflated, lung is retracted, and those sort of things are done, and it may add to the damage to the pulmonary parenchyma. So in those patients, I think you should try to avoid thoracotomy, and approaches which used to be costotrachectomy many years back. It used to be done in those patients which were very poorly. In these patients, you just remove part of the transprossus and part of the rib and go anteriorly into the vertebral column. Now, I think it is widely used. We do it very regularly. We have been doing it before, and it works very well. So I think
Okay.
answer to your question is yes. I think a pulmonary specialist should be involved.
Okay, another question. My question is, what is the most commonest cause in Pakistan, in your opinion? And so that we can avoid from this most commonest cause, what you think as a in your experience?
Commonest cause of what?
This is pulmonary cox, spinal cox.
Well, I think okay, let's put it a little less than optimal situation. I think it's your clinical judgment, it's your patient history, physical examination, and your own high index of suspicion, because हमारे यहाँ tuberculosis is still there. So, but having said that, हमारे यहाँ the other lesions, comorbid condition, the diabetes is there. Diabetes is one thing which is very bad for a patient, because it will produce not only immune deficiency, but also produce other microangiopathic lesion, which does not which helps in elimination of pain. Neuropathy hai to pain mareez ko hogi nahi. And these patients sometimes they present with what is called as Charcot joint of the spine. Tuberculosis nahi hogi, MRI ke upar wahi lagega ki shayad tuberculosis hai, but there's no abscess there, and there is just granulation tissue, which is a chronic granulation tissue and debris in that area, and that is because of diabetic neuropathic changes in the spine, which is a Charcot of the spine. They have instability there, they have erosion of the two end plates, and they have, if you look at the MRI, there's some granulation, there's some, soft tissue there, there is some inflammatory changes there, there may be some chronic granulation tissue, not tuberculosis, but if you aspirate it, उसमें कुछ भी नहीं आता, सिवाय इसके कि जी वो non-granulomatous infection नहीं, tissue है, which is inflammatory in its end, and patient develop various kind of neurological problem. Usually they present with pain on ambulation, pain on turning sides, and वो लोअर लेग में पेन होती, मगर नॉर्मली वहां पे शायद स्पाइन में इतनी ज्यादा नहीं होती, because diabetic neuropathy has contributed towards loss of sensation in that part of motion segment.
Thank you. Dr. Shabir Saab is there. Dr. Shabir is also orthopedic, and last week was his presentation. Shabir Saab, कोई आप कमेंट करेंगे?
Shabir साहब बड़े अजीम आदमी,
कमर के दर्द के बारे में, कमर के दर्द में आपकी बड़ी अच्छी can you comment about this, about very nice lecture about the Professor Tariq Sohail? Thank you. Can you give some comments, Dr. Shabir Saab? Dr. Shabir Rahman Saab, you can unmute and Dr. Shabir Rahman, मैंने unmute
Shabir Rahman साहब अगर नहीं तो मैं उसकी जगह जवाब दे देता हूँ.
Dr. Shabir Rahman बोलेंगे. Dr. Shabir Rahman आप unmute करें. Okay.
शबीर साहब,
जी जी, अपनी शक्ल भी दिखाएं सर। जी डॉक्टर शबीर अमान जी, थैंक यू डॉक्टर शबीर अमान, अस्सलाम वालेकुम।
हाँ लेकिन जी शबीर साहब, क्या हाल है आपका? आपका रोज व्हाट्सएप के ऊपर देखते रहते हैं, माशाल्लाह, यू डूइंग ए ग्रेट जॉब।
अच्छा जी सर, कैन यू गिव फ्यू कमेंट्स अबाउट tuberculosis in Sarhad, KPK, spinal especially?
आवाज नहीं आ रही, बोल रहे
आवाज
हैं।
नहीं आ रही सर, वी आर नॉट हेयरिंग यू। Okay. If anybody other can ask the question before the Professor Shabir reply. Dr.
बुखारी
Rashid
साहब,
साहब।
बुखारी साहब,
जी सर, राशिद जी
The-
सर, एक मिनट। जी सर।
the backache, patient presents with a backache.
जी जी।
अगर यूजुअली अगर उसकी और कुछ भी नहीं है, अगर वो 15 दिन, महीना, 1.5 महीने में वो सेटल नहीं होती बैकएक, एंड द पेशेंट स्टिल कंप्लेनिंग बैकएक along with the systemic symptoms here and there, don't hesitate to get the MRI done along with that inflammatory hematological test. क्योंकि हमारे यहाँ यूजुअली डिसमिस किया जाता है कि जी कोई गल नहीं है, कमर की दर्द हुई, पट्टा खिंचा
हाँ
गया,
हाँ हाँ
sort of
हाँ
thing.
हाँ
I think
सर।
these symptoms, they can be not dismissed, they can be treated symptomatically for a limited period of time. But if you cross those limits and the patient still complains of pain, patient along with that, there may be a systemic symptoms and etc. Or there may be some difficulty in executing his job, whatever he is doing it, then don't hesitate to get the radiological and hematological and the MRI done in the same patient. वो चाहे उसको लगे कि जी मेरे पैसे बड़े खर्च हो गए, but I think it's worth it.
उसकी लाइफ पर। अच्छा जी, जौहर हुसैन, डॉक्टर जौहर हुसैन, you want to ask the question, you can unmute. Okay, I have unmuted you. You can ask in both English and Urdu. Dr. Jauhar Hussain. Dr. Jauhar. Dr. Jauhar
I
Hussain
think
from
there's something
Karachi.
wrong with
जी
everyone's mic.
जी, Dr. Jauhar, you are from Karachi. जी, you can ask the question. I think what is the problem, Wadeed? They cannot. Jauhar has raised the question hand.
But he is
Okay.
not unmuted his mic. शबीर
Okay.
का mic unmuted है लेकिन आवाज नहीं आ रही.
डॉक्टर मलिक महमूद साहब।
जी जी,
डॉक्टर मलिक
मैं डॉक्टर जौहर बात कर रहा हूँ। ये जो है, ये डॉक्टर साहब से जो है, ये मेरा सवाल है कि एक वाहिद, जैसे हमारे पाकिस्तान का जो है थर्ड वर्ल्ड कंट्री है, तो उसमें पेशेंट आते हैं, तो मैं भी जो है चेस्ट फिजिशियन हूँ, तो जैसे आप बता रहे हैं कि ये लोअर बैक पेन है, तो इसमें एक वाहिद एक टेस्ट मुझे ऐसा बता दीजिए कि जो हम पेशेंट के साथ करवाएं और हमें ये पता चले कि ये स्पाइनल ट्यूबरकुलोसिस है।
देखिए, there is no single test to begin with, but I think persistent of the pain and symptoms along with the raised ESR, that will raise your level of suspicion that there is something going on underneath. And raised ESR will give you sort of indicator that आपने किस direction में जाना.
Okay, very good answer. I think as a pathologist, very simplest, I cannot elaborate all the tests, but simple ESR, if rising and not coming down after some treatment, may raise suspicious. Professor Mahmood Saab is Professor of Hematology at AJKMC. G. Mahmood Saab, you want to ask something or add something? Professor Mahmood.
Sir, Professor Murad Bhai Saab, thank you very much for organizing such a nice symposium. Meeting rather. I have a question from Professor Sohail Sahib. Role of gene expert is well known and well practiced in pulmonary tuberculosis.
Okay.
But how it plays a role in the TB of spine? Number one. Number two, obtaining a biopsy seems to be very difficult when it comes to the TB spine. So, is there a role of FNAC which may be of help?
Dr. Tariq, yes, Dr. Tariq.
I agree that एक तो देखें रेज्ड ESR C reactive protein gives you indication. बायोप्सी आपने लेनी है, बायोप्सी इज नॉट डिफिकल्ट टू टेक. द बेस्ट आप तो या तो खुद अगर आप लेना चाहें, इफ यू आर एक्सपर्ट इन दैट, यू कैन डू सो आइदर थ्रू द पेडिकल और एक्स्ट्रा पेडिकल अप्रोच. अगर आप नहीं करना चाहते, यू आर नॉट ट्रेन्ड, then either you can ask your radiological colleague को CT guided biopsy ले लें. And CT guide will give you the sort of CT के ऊपर ही appearance होगी कि आपका destruction कहाँ पे है. You can put your needle there and you can take aspirate and you can take the pus and soft tissue, whatever it comes, and you can subject the soft tissue to histopathology. And the pus, whichever, the fluid, whichever comes to gene expert and other sort of sim kind of trust, and it will give you the diagnosis within 24 hours or so. तो दूसरा FNA, I think agreed, FNA वो है, मगर FNA will not get the tissue. It will get some cells which may not represent the pathology which you're looking for.
और दूसरा सवाल था जीन का, उसका सवाल था जेनेटिक, रोल ऑफ जेनेटिक इन द डायग्नोसिस ऑफ, उनका एक सवाल ये भी था
जीन एक्सपर्ट का.
जीन एक्सपर्ट का.
हाँ, gene expert is available in government and the private. In the spinal, it is equally effective.
Yes, yes.
What?
But the specimen is blood are to be obtained from the spine.
Spine, from the spine.
से आप CT guided transpedicular, अगर आप surgeon हैं तो you can do it yourself. If
From the
not,
spine.
radiologist will give you CT guided or ultrasound guided biopsy. अगर आप श्वास sepsis ले लें, आप उसी को तो उसको जीन एक्सपर्ट के लिए भिजवा दें. उसके अंदर PCR ही करना है ना, PCR वगैरह हर चीज कर. तो सिमिलरली
डॉक्टर महमूद, इसका जवाब मैं दूं. ऐसा है कि क्योंकि आप और मैं पैथोलॉजिस्ट हैं, एक्चुअली बेसिकली रोल बड़ा लिटिल रोल है. एक तो FNA का हार्ड होता है टिश्यू का, अगर ग्रेनुलेशन टिश्यू से FNA है तो हो सकता है ग्रेनुलोमा नजर ना आए. एक बात. दूसरी बात है जीन एक्सपर्ट इज गुड, लेकिन उसके लिए जो इसमें ट्यूबरकुलोसिस एक्टिव है तो ब्लड में आएगा. अदरवाइज जहाँ से सैंपल ही होगा ना, उसी से ही हमें जीन एक्सपर्ट लेना पड़ता है. तो
Sir, I have one more question.
जी 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 बिल्कुल पूछें.
If the patient is not willing for the biopsy or FNAC, then is there a role of sequential MRI in the diagnosis of Pott's disease?
Oh,
MRI changes will tell all the sort of radiological changes which you expect in chronic inflammation, but it will not give you okay, this is tuberculosis or not.
डिफरेंशियल डायग्नोसिस नहीं हो सकेगा.
हाँ, वो नहीं उसको क्लैरिफाई करेगा. मगर अगर आप उसको चाहते हैं तो ट्रीटेड, अगर वो मरीज नहीं चाहता कि सर्जरी बायोप्सी नहीं करनी, then you can have a treatment which is informed consent treatment के जी आपने blind treatment शुरू किया और empirical treatment शुरू किया एंटी tuberculosis से. There are a lot of people do it in this part of the world. आपने 6 हफ्ते एंटी tuberculosis treatment या 3 महीने आपने दिया. If the response is good, response in terms of clinical response and also radiological, no, not radiological, but you can call it hematological ESR वगैरह. If it's a ESR is coming down, the patient is feeling better, then you can assume that you're dealing the right pathology and you can carry on the same treatment which you instituted in the first 6 to 12 weeks, and you can carry on. At the same time, you should give some kind of support or some kind of postural exercise and training so that patient during even the healing process does not go into kyphotic deformation, because even in being healed and being treated, patient will go into kyphotic deformation because adequate treatment जब तक वो पूरी तरह heal नहीं होता, it will lead to kyphosis over the period. So I think brace and the posture training is important along with
thank you.
Thank you so much.
Thank you.
डॉक्टर महमूद, एक्चुअली बेसिकली वो ब्लाइंडली ट्रीटमेंट करना डिफिकल्ट होगा. वाकई पेशेंट काफ़ी सारे होते हैं जो सर्जरी के लिए वो नहीं करते, डायग्नोसिस नहीं हो सकती, बट वी मस्ट ट्राई आवर बेस्ट टू कन्विंस द पेशेंट टू, उसके खर्चा बच जाएगा और उसको प्रॉपर ट्रीटमेंट होगी. तो आई थिंक कन्विंसिंग काउंसलिंग ऑफ द पेशेंट इज़ वेरी इंपॉर्टेंट. नॉट ओनली द पेशेंट, उनके लवाहिकीन के साथ भी कन्विंसिंग काउंसलिंग बहुत ज़्यादा ज़रूरी होती है. ओके जौहर, हैव यू ओपन, हैव यू चेंज द माइक टू आस्क द क्वेश्चन? और डॉक्टर शबीर साहब, आपका मैसेज आया कि यू आर नाउ रेडी टू टॉक समथिंग. जी डॉक्टर शबीर अवान साहब. ओनली द लास्ट क्वेश्चन बाय शबीर अवान साहब.
जी जी जी, मैं यही बात कह रहा हूँ कि बात जो अभी डॉक्टर साहब ने सही बताई कि ये एक पूरे सिनेरियो में होगा कि जिसमें ESR, CRP और MRI वगैरह सब इंक्लूडेड होंगे, तो फिर हम किसी डायग्नोसिस पे जा सकते हैं।
हाँ बिल्कुल
और
बिल्कुल
दूसरा
बिल्कुल
ये कि क्रॉनिक होगा और इल होगी, जैसे अभी सर ने कहा कि उसका एग्जामिनेशन हिस्ट्री
हाँ
everything is included in the investigation going to the diagnosis of the lower back pain with the Pott's disease. Okay,
थैंक
yes,
यू
sir.
थैंक यू। कैसर कैसर सज्जाद साहब, सेक्रेटरी जनरल PM में कैसर सज्जाद साहब। लास्ट क्वेश्चन, लास्ट कमेंट्स बाय डॉक्टर कैसर
Thank
सज्जाद
you.
साहब।
Thank you very much, Mulazim Sahab.
सर
Actually,
वेलकम सर।
I just endorse whatever you said about the FNA and the biopsy. The only technique is to convince the patient to have a documentation. You are not patient को ये बताना है कि we are not and nobody is knowing what it is. So उसके लिए diagnosis हम करने के अगर नहीं होगा तो how can we treat? तो पेशेंट जो है हमारे साथ भी एज ए ENT सर्जन बहुत सारे ऐसे आते हैं जो लोग नहीं कराते हैं, लेकिन एट द एंड वो कन्विंस हो जाते हैं जब उनको पता लगता है कि हाँ हमारे पास तो कोई डॉक्यूमेंटेशन नहीं है। अगर हम रेडियोथेरेपी के लिए भी भेजते हैं, कीमो के लिए भी भेजते हैं, तो उनको डॉक्यूमेंट चाहिए होते हैं कि व्हाट इट इज। तो सो यू आर एब्सोल्युटली राइट मुलाजिम साहब कि हमें कन्विंस करना चाहिए कि ताकि उसकी डॉक्यूमेंटेशन हो जाए। सेकेंडली डॉक्टर तारिक से मैं ये पूछना चाहता हूँ, एक तो बहुत जबरदस्त तारिक साहब, योर प्रेजेंटेशन वाज एक्सेलेंट। मैं कुछ चीजें मिस कर गया हूँ, कुछ अपनी वर्किंग भी कर रहा था साथ में, तो मैंने पूरी आपकी प्रेजेंटेशन नहीं सुनी, लेकिन बहुत इंफॉर्मेटिव वो थी सारी चीजें आपकी। और मैं सिर्फ एक चीज पूछना चाहता हूँ कि ESR की जो आपने बात की थी कि ESR तो अब मेरे ख्याल में ऑब्सोलीट हो गया, उससे डायग्नोसिस उसको तो हम इतना इम्पोर्टेंस देते नहीं है। तो इज इट अ ट्रू, और मैं गलत हूँ इस चीज में कि ESR आप उसको इतना कंसिडर नहीं करते?
ESR आउट ऑफ डेट तो नहीं हुआ, it is still valid and it is still one of the very economical, very you can do it everywhere, even in the small district.
बहुत सस्ता सा टेस्ट है, बहुत सस्ता सा टेस्ट है और
बहुत
बिल्कुल
सस्ता टेस्ट है, but it will give you diagnosis नहीं करेगा, but it will give you the direction which
आइडिया
is going.
आइडिया
आपको आइडिया दे देगा कि जी इन्फेक्शन हो रही है या whatever we are treating is not being treated right. There is something more need to be done, just an ESR. Along with आप उसको मरीज की जो ओवरऑल हेल्थ है या सिम्टोमेटोलॉजी है आप उसको देख लें. If that is not going away and the patient is still sick and getting sicker every day, the ESR is still raised or raising instead of getting better, that means that patient needs to be evaluated even further and much more detailed. तो पेशेंट को आप अगर बताएं, जो आपने पहले जो भाई साहब ने कहा कि वो सही है, पेशेंट को बताना जरूरी है इन देयर ओन लैंग्वेज कि जी अगर अगर आप नहीं करते तो आपका नुकसान ज्यादा हो सकता है, विच मे कॉस्ट लॉट ऑफ मनी एंड मे कॉस्ट हिज प्रोफेशन एज वेल. So I think it is important to make them understand and realize the gravity of the situation. Just giving few medication without any वो कोई नहीं है. So patient चाहे अनपढ़ भी हो, they will still understand to certain extent and they sometime वो ठीक ठाक समझ
डॉक्टर कैसर साहब, मैं आपको बताऊं कि हमारे जो कोविड आया ना, तो उसमें उस वक्त बहुत ज्यादा मुश्किल टेस्ट थे, लेकिन ESR CRP ये दो ऐसे टेस्ट थे जो हमें एज ए पैथोलॉजिस्ट हम लोगों को कहते.
अच्छा, लेकिन मुलाजिम साहब यहाँ पे मैंने देखा कराची में जितने भी टेस्ट हुए तो उसमें ESR नहीं होता था, वो दूसरे होते थे। तो मैं यही, और मेरी जो फिजिशियन से इंटरेक्शन हुआ तो उन्होंने कहा कि जी ESR तो अब नहीं कराते, INR कराते हैं और दूसरे 2-3 चीजें ऐसी होती हैं, तो वो उससे वो करते हैं, क्लू मिल जाता है उससे। तो अब इंटरनेशनली ESR इतना ज्यादा इम्पोर्टेंट नहीं रहा। तो लेकिन ऑफ कोर्स यू आर एब्सोल्युटली राइट, मैं बिल्कुल तारिक सोहेल साहब आपसे एग्री करता हूँ कि हमने जो पढ़ा कि जी ESR, हाई ESR जो है वो सिग्निफिकेंट होता है, लाइक कार्सिनोमा एंड ट्यूबरकुलोसिस और ये वो सारी चीजों में, तो वो तो क्लू मिलता है हमें। तो that is absolutely right. Thank you very much. आपने बहुत अच्छा बताया
प्रोफेसर
मुझे।
सजाद, मैं आपको एक मेरे उस्ताद, अल्लाह मरहूम जन्नत करे उनको, प्रोफेसर कुरैशी साहब थे। वो दो बातें पढ़ाया करते थे, पुराने उस्ताद थे और मैं भी पुराना स्टूडेंट हूँ। वो कहा करते थे अगर 200 के करीब आपका ESR जा रहा है तो समझें कि ये आपको कैंसर हो गया है, और आपका 100 के करीब टच कर रहा है, 150 के करीब, तो एक जहन में रखें कि ट्यूबरकुलोसिस पाकिस्तान में होती है। तो उन्होंने कहा कि मैं एक दफा गया, मैं अमेरिका में अपनी वो कर रहा था डिप्लोमेट, तो उन्होंने ग्रेनुलोमा का डिफरेंशियल डायग्नोसिस रखी, वहाँ TB नहीं होती अमेरिका में। तो मैंने
वीकेंड
जी पहली लिसन, तो कुरैशी साहब ने कहा मैंने पहली डायग्नोसिस
कब तक है? ये क्या कहूँ मैं?
तो ये उसने कहा कि आपने
या राशिद भाई अपना म्यूट कर दे। राशिद भाई आपका
राशिद साहब
माइक्रोफोन
म्यूट
ऑन
कर
है।
दे। अच्छा, तो कुरैशी साहब कहने लगे कि मैंने उससे कहा, मेरे सुपरवाइजर ने आस्क व्हाई हैव यू केप्ट द डायग्नोसिस, डिफरेंशियल डायग्नोसिस एट द टॉप एंड द TB, यहाँ अमेरिका में तो TB नहीं होता। तो उसने कहा कि सर मैं इसको, उस जमाने की बात है, ESR वाज वेरी हेल्पफुल इवन इन अमेरिका, नो डाउट्स। कैसर सजाद साहब, नई मोडेलिटीज आ गई हैं, लेकिन CRP एंड ESR स्टिल वेरी चीप, और पेशेंट को एक क्लू दे सकता है कि किस तरफ। अदरवाइज जैसे जीन एक्सपर्ट है या दूसरी चीजें, उस पे जाएंगे एज ए मैक्रोबायोलॉजिस्ट, तो फिर जब तक कंफर्मेशन नहीं होती उस वक्त तक ट्यूबरकुलोसिस आप नहीं कर सकते। थैंक यू फॉर टाइम।
Thank you very much.
बुखारी साहब एक मिनट, बुखारी
जी,
साहब
जी।
एक मिनट, वो
जी, जी, जी।
एक हमारे कोलीग ने अभी कहा था कोविड के बारे।
हाँ,
कोविड
मैंने कहा था
I think something different I'm going to describe in just 1 minute.
हाँ,
COVID is a thrombotic disease, and
हाँ,
it has been treated with, or usually has been treated with steroids. ठीक है?
यस जी, मैं उसमें तारिक सोहेल साहब, मैं ये कह रहा था कि बहुत सारे और टेस्ट थे, तो
जी।
उसके बाद
नहीं,
एंड
मैं
पे
एक
आया
और-
ESR कैन नॉट बी ओमिटेड।
नहीं, मैं तो अभी पूरी बात नहीं करनी।
अच्छा,
इसका
हाँ,
TB से कोई तल्लक नहीं है। COVID and steroid has resulted into a lot of patients with avascular necrosis of head of femur, usually
अच्छा,
bilateral, and I am seeing quite a number of patients presenting with the pain in the hips. They have a COVID infection, they have been treated with the steroid, and I'm dealing with a biological sort of a procedure in that. I'm using various bone morphogenic proteins and the kind of mesenchymal cells. So presuming that the avascular necrosis has produced dead bone, and they repopulate and reignite the cellular element and regenerative element in that area. And so far I have done a small series. I'm going to present it as a concept internationally very soon. अभी जो पेशेंट हैं they are doing very well, and इसमें quite a number of patients they are अपने medical colleague ही हैं. So I think what I'm saying is the purpose of saying to this audience is that any patient present with pain in the hip, a history of COVID infection, you should go for MRI examination. Rule out there is no avascular necrosis in those hips.
थैंक यू सो मच प्रोफेसर तारिक सोहेल साहब,
Short of,
वेरी
short of total hip replacement, उसकी कोई अभी जरूरत नहीं है. When the head is still spherical, you can treat it in a biological sort of assisted surgery.
Can I ask a question?
over to you.
Professor Tariq Saab,
जी.
it was a great piece of talk. Thank you so much, and we'd love to have you again. This has triggered my interest because COVID is an area which I'm very, very interested in, and especially the hip pain. What I want to ask you is that in COVID, short courses were given of steroids, not prolonged, and even they caused these changes.
जो मेरा अपनी थिंकिंग है, एक तो स्टीरॉयड चाहे हेड इंजरी वाले मरीज देख लें, स्टीरॉयड उनको चाहे शॉर्ट टर्म दिया गया हो, some of them they still have avascular necrosis because of thrombotic changes in the neck of femur को जो head of femur की जो arteries हैं circular वगैरह जो COVID है, that is a thrombotic disease. It will produce a thrombosis in the small vasculature, and along with that, it will steroid जो है that will add to the thrombotic sort of propensity, and the patient, not all patient, few of the patient do develop avascular, which is more than average what we see in given setup. हमारे यहाँ अभी लाहौर में पाकिस्तान में मैंने quite a number of patients देखे, उनकी association बड़ी strong है इसके साथ steroid along with the COVID and avascular necrosis.
Okay, Sergi.
I'll
We'll
be very
invite
happy
you again for a talk on
give
this.
a small presentation and talk on this COVID and avascular necrosis and their relationship and how I treat it. It is not documented as yet, but we are going to publish it internationally.
Inshallah, inshallah. We'll have you again for this talk specially. It was a pleasure listening to you, Dr. Tariq Sohail, and we'd love to have you again. And I thank you on behalf of the
Thank
Pakistan
you,
Medical
madam.
Association.
Very kind of you. Thank you, Malazam Sahab.
Thank you, sir. Thank you, sir.
Thank you.
Inshallah, see you next time.
participated.
Allah Hafiz.
Everybody have a nice
Thank you.
weekend.
Thank you.
Allah ke hawale.
Thank you. Allah Hafiz.
Allah Hafiz.